This is a webinar sponsored by Procare Health to highlight the importance of medicine-based evidence in the field of phytotherapy. We have the opportunity to take profit of two excellent key opinion leaders, Professor Santiago Palacios from Spain and Dr. Cláudio Rebelo from Portugal. Both are well known in their files and has both an fantastic and enormous experience on menopause. Professor Santiago Palacios has been a very important person in many international societies, so don't need more extensive presentation. He was licensed, he obtained a degree in medicine from the University Complutense of Madrid. He was the founder of the first menopause unit in Spain, and nowadays he is the director of the Palacios Institute of Women's Health and Medicine. Is a private center in Madrid that combines both medical care and research. And in this sense, he is the author of more than 400 scientific papers. I don't know any other author with such amount of published papers. And also most of them with a special emphasis on menopause, osteoporosis, and female sexual function. Moreover, he has been the principal investigator in over 100 clinical trials, most of them funded by the industry. And he has served as president and board member of many scientific societies, such as the Spanish Gynecology and Obstetric Society, the Women's Health Foundation, here also in Spain, and the Foundation for Osteoporosis and Bone Metabolism, also in Spain, and the Spanish Society of Menopause, the Council of Affiliated Menopause Societies, the International Menopause Societies, who is a man devoted to the study of menopause and very well known for all of us. Santiago, since it appears that Professor Rebelo has some problems with his connectivity, please start with your lecture from phytotherapy to evidence-based medicine, and express the results of the studies of LIBIRTY and LIBIDOBS studies in menopausal symptoms. Both studies follow the rules of medicine-based evidence. So please, Santiago, explain us these studies and the results of both interesting research that I was part of this research.
I am going to do. Well, thank you very much, Camil. This is a pleasure to be involved in this important webinar. Well, the issue for me is that we have a lot of attendees around the world. This is something nice. I am going to try to explain in detail our studies about the phytotherapy in relation with the menopausal symptoms. These are my conflict of interest disclosures. Well, this is going to be exactly the agenda that I am going to speak.
Dr. Santiago, we cannot see your slides.
No?
Not yet.
Let me, I don't know why. I'm going to compose. Now, yes. You can?
Yes, Santiago, we can see now.
Yeah, we can see. Okay. Well, this is exactly the agenda that I'm going to speak. What I said before, this is my conflict of interest. This is the agenda. First of all, I am going to explain why we need to speak about the phytotherapy. This is something in relation with the SURE decision. You need to offer to our patients all of the possibility that we have in our hands. This is unclear, and this is important to say. Well, and of course, we need to explain the efficacy and the side effects to all of the different possibilities. Because, this is the second point, our patient, they have some particular own opinion, and they have the point of view of them we need to take in account, because this is impossible in terms of having a good compliance if you don't understand what exactly are the ideas of our patients. And finally, I'm going to present two beautiful studies with some of these new phytotherapy food supplements that we have new approach and new ideas. Move on to the short decision making. This is something that is fundamental in this time that we are living. If you have a beautiful short decision, you are going first to improve the relationship between doctor and patient. You are going to reduce the regret after the decision is taken. And of course, you are going to improve the compliance and the quality of life. No doubt. I understand that we need to spend some time with our patient because we need first to explain what are the guidelines, the treatment options, and the scientific evidence. This is so important. On the other hand, we need to understand the clinical patient profile, the risks that they have, the comorbidities, and you need to take and to understand the possibilities in relation with all of these issues. And finally, but so important, is to wait time and to understand the personal value, what worries they have the patient, the preferences, the lifestyle. These three, in this slide you can see these three important parts. These are the reason for having better or no compliance with the different possibilities that we have. I don't like that you see this slide. It's only to say, of course, this is the reason that the algorithms that the different society has, like this, for example, are enormous because we have different products, we have different kind of patients, and we need to take one decision, but a shared decision with our patients. Move on to the second point of my talk. This is in relation with one point of view is our point of view, the doctor point of view, but another is the patient point of view. And this is ridiculous. For this, we need to wait time and to speak together. For example, a large number of menopause women, they don't like to refer or to explain and to speak about their own symptoms with the doctors. Maybe we need to be clever and to try to have more data with our patients. There are several papers that they show that one thing is our ideas and another the patient ideas in relation with menopause. Look, this paper done in Spain, for example, they say that non-hormonal therapy is used by 73% of our patients. And of course, the patient want more information, but more or less 50% of the menopausal women do not consult physician and only 16 seek training. In other words, time and the short decision of the different possibilities is something fundamental if we would like to have successful in our clinics. And this is one of the reasons to speak now about the different phytotherapeutic combination that we have now in our hands. I know that 10, 20 years ago, the phytotherapy was a very controversial issue. The result, the efficacy of the result, they were not nice, with a good safety profile, but in general, we thought that phytotherapy was not the best option. But now, there are important changes, important ideas, important combinations that I am going to offer in this moment. Now we have studies, we have trials. We have these 3 trials that I was doing during the last time. The Libby pill that was published some years ago in a PubMed journal, that means that with impact factor. But now I am going to speak about the LIBIDOBS and LIBIRTY, these 2 studies that are in progress. One, the LIBIDOBS is in relation of the libido, the sexual dysfunction, female sexual dysfunction, with a new approach that is so nice. And then I am going to explain the LIBIRTY study that is in relation with menopausal symptoms and with a new, different approach. Look, because this is something logical. Of course, you can say hormone replacement therapy is the goal option, no doubt, for severe or moderate severe symptoms. But we have a lot of patients that they have mild or mild moderate symptoms that maybe you can start with this approach, and then after 3 months, you can move for an HRT or other medical treatment that we have now for hot flashes. Move on. For example, we have a beautiful products in a lot of different countries in the different continents. That this is something very logical. I like to explain the philosophy of this product. We combine 3 natural products, Trigonella, Tribulus, and Damiana, that are food supplement very well known around the world, that there are several papers to show that Trigonella increase the sexual function in ladies, Tribulus 2 and Damiana. And the idea was, why not to combine all together to try to have the best food supplement for female sexual dysfunction. And this is exactly what the study that I like to present here. It's a multicentric observational perspective and non-comparative study. This is true. But well, if you have results, you have results. And the most important, in my opinion, of these natural products is the Trigonella. Because you know the Trigonella increase the endogenous testosterone, and this is the mechanism of action for work in this area. The primary objective of this study was to evaluate the improvement of sexual function, and then we have some different secondary objectives that you can see here. We did 3 visits, the basal one after 2 months and after 4 months. The number of patients you can see, no bad, 116 patients, postmenopausal women from 45 to 65 years, and with low sexual desire. And we did all of this issue, the menopause visual analog scale, the free testosterone, we determine free testosterone, because, well, we understand that the questionnaire, they are not objective, they are subjective area. But if you put together one questionnaire plus one objective point as the free testosterone, is something that they can give some value to this study. You can see here the result of this study with this combination of Trigonella, Tribulus, and Damiana. You can improve all of the different domains after 4 months, no doubt. But the good point you can see in the right part of the slide is that you increase the free testosterone too. In other words, with this combination of natural products, you are going to increase the free testosterone and all of the clinical sexual domains in a significant manner. This is something very provocative. And at the same time, we analyze after 4 months the degree of satisfaction, the compliance and tolerability that you can see that were fantastic, all of them. In conclusion, we think that this natural food supplement with 3 natural products, Trigonella, Tribulus, and Damiana, works because they increase one objective point, that is the free testosterone, but at the same time, clinically speaking, you increase all of the domains in sexual function. This is something important. Move on to the LIBIRTY study. The LIBIRTY study is an observational study too, but this is something very provocative with 2 different capsules. One to take in the morning with more or less the same thing that the study before, with Trigonella, Tribulus, Damiana, and Ginkgo biloba, that is about for vasodilatation to increase the blood flow in some areas. But at night, you prescribe black cohosh and luprenol lupulus to try to decrease the number of hot flushes, and if you add melatonin too, to try to have better sleep or better or more hours to a good sleep if you have a sleeping disorder. This is something very provocative, is to try to have the best thing with natural products of food supplements to increase the quality of life of our patients. And there are so many patients with mild and moderate symptoms that they can be happy with this formulation. The study was a single-center observational perspective study, and the most important objective was the effectivity of this supplement in terms of decreased symptoms and increased quality of life. We did one study with 3 visits too, the basal one after 1 month and after 3 months. The number of patients were not very high, was 33 only, but well, enough to know this is something pivotal and we need to have more trials. All of the women, they were menopausal and with a low quality of life, in other words, with symptoms. Here you can see exactly the results. All of the vasomotor symptoms, they decrease after 3 months, 81.8, very significant. What you have there, exactly the menopause symptoms in general, the vasomotor symptoms, the health and the aging. Well, the results, they are excellent. Of course, you can say, we need to do one double-blind placebo-controlled study. Yes, but this is a pivotal study, and this shows what is going to be in the future the next way for doing it. We did too the short Cervantes questionnaire that we have in Spain, that is in relation with menopause, and we had exactly beautiful results too. That means that with the 2 major questionnaires, we can say that the use of this combination, 1 pill in the morning, 1 pill at night, this works very nice. Of course, we add in this combination, this is like to have in our mind, this is the ideal natural food supplement. In one ideal natural food supplement in postmenopausal women, you need to add, as we did, something with some melatonin, we did. We need to add vitamin D, of course, because the vitamin D is the vitamin D. And we, in this study, we can demonstrate what this vitamin D, we can increase exactly the vitamin D levels in blood, of course. This is a very objective. This means, again, that the questionnaire are there and they are subjective points, but we did some objective point as the determination of vitamin D in blood is. In conclusion, with this combination that is different in the morning than at night, we have a beautiful result, around 80% of improvement in vasomotor symptoms and in quality of life with a good tolerability and with a good satisfaction. Finally, this is my last slide. What is the idea? When I present this kind of products, as I said before, is not to say, well, this is my better than HRT. No. Hormone replacement therapy is a gold standard. Hormone therapy in the menopause is a gold standard. The new products that we have for hot flashes, they are fantastic too, with beautiful phase 3. But we need to cover some areas as the mild and moderate symptoms are. We need to cover to women that they prefer to take natural supplements before one drug. And my idea is you can, first, always you need to prescribe the typical good diet, exercise, and good habits, you know. But the second step is to offer one natural fat supplement. And finally, if after 3 months is not enough, of course, you can add menopause hormone therapy or the new drug that we have. That means that one thing are the different products that we have. One thing is the patient that you have in front. We need to share and to make a short decision, and after this, you can take a decision. But the fat supplement are there. This was exactly the idea that I have, and the works that I saw now are in relation with this idea that I have. Thank you very much.
Thank you, Santiago, for your nice presentation. And now it's time to remind to all the audience, please send your questions to the question answer section in this Zoom platform. I am sure that we will receive a lot of questions because Santiago, as usual, you perform a very nice and excellent presentation. Our next speaker is Dr. Rebelo.
Thank you.
Who obtained his degree in medicine in the University of Porto. He is a specialist in gynecology and obstetrics and the coordinator of the specialty at the CAF Porto Hospital. CAF is the most important private medicine group in Portugal, and the CAF Hospital in Porto is the most important private hospital in the north of Portugal. Dr. Rebelo, he is an expert in several gynecological files, such as oncology, laparoscopy, menopause, and the treatment of endometriosis, so he can speak about every topic in our specialty. Professor Rebelo actively participates in different scientific medical societies, being nowadays the president of the Portuguese menopause section inside the Portuguese Society of Gynecology. He's also a member of the Portuguese Society of Contraception and usually perform and do different lectures on topics related to family planning. It is my pleasure to introduce Dr. Cláudio Rebelo, a good friend of mine, with the topic, the physiopathology of menopausal symptoms, from vasomotor symptoms to genitourinary syndrome of menopause. Cláudio, is your time.
Thanks a lot, Camil. Thanks for the nice introduction. I'd like to thank Santiago for having the opportunity to talk in the same webinar as him. It's an honor for me to be with both of you here today. And I hope without any informatic problems, I'll start my lecture. So as you were saying, I have these conflicts of interest, but the most important of my conflict of interest is the last sentence. These are my views only. All our opinions are my own, and any errors on this presentation are, of course, mine. This is the outline for my presentation. We are going to talk a bit about thermoregulation of vasomotor symptoms, the CANDI, the neurobiology behind this central pacemaker, the pathophysiology caused by the drop of estrogens, and talk about GSM and microbiome mechanisms, and then ending talking about the most common phytotherapies that you can use for treating women in menopause. As you all know, we all work with this straw reproductive aging workshop classification, but really for the clinical, this is very nice for the papers, this is very nice for investigation, but for the clinical, when we talk about menopause and post-menopause, we always have to say that we have different women, and sometimes when we look at all the levels of EFH, inhibins, even anti-Müllerian human hormone, we don't need it that for the clinical practice. We need to know symptoms, we need to know how the patient feels and how the patient feels in these 5-6 years transition to menopause and then the rest of her life in menopause. So most important is not looking at the numbers of hormones, at the values of hormones, but it's the clinics and it's the symptoms and it's the type of knowing how to talk to patients and ask the correct questions to have the right answers. And so when we talk about this, thermoregulation, vasomotor symptoms, it's time to do the correct questions so we can have some answers. And when we talk about the different hypotheses of the physiology of vasomotor symptoms, of the thermoregulatory model of hot flashes, we have to understand that it's the estrogen withdrawal that alters that set point control in the hypothalamus. We start to have a narrower thermoneutral zone, and then we have all the phytopiral signatures of the skin relief, the pseudomotor outflow, the flashes, the cutaneous temperature going up. And all of this tries to explain, with that hypothesis of the thermoregulatory model, the people that have more hot flashes in summer, less hot flashes in winter, that people that live in colder countries have less hot flashes, hotter countries have more hot flashes. But if you stick to this thermoregulatory model, what we have is that drop of estrogen levels would work in two places. In the thermoregulatory center, because the lowest that we have of estrogen, we are going to start having pulses of GnRH, LH, and FH levels that goes up. This change, this hyperactivation of the GnRH secretory neurons would change the thermoregulatory center. The thermoregulatory center would have a narrow zone, and so when people were exposed to hot, or when people were exposed to cold, they will have the hot flashes. We also have to know that this drop of estrogen levels also works in the serotonergic pathway, and so we have an increase in serotonin receptors, but we don't have the neuropeptide there. That's why SSRIs can be used in low dose to treat hot flashes in women with breast cancer, for example. That's why, because we don't only have this thermoregulatory center, but we also have the pathway of serotonin to increase and to make these hot flashes appear. When we talk about this, we're going to have asymptomatic women with a nice upper threshold, a nice lower threshold, and so they have that thermoneutral zone where they can stand change of temperature, where they can stand change of serotonin levels in the synapse, and they don't get symptoms. But then when estrogen drops, all of this is going to be a lower, a narrowed threshold zone, and so it appears the hot flash because this thermoneutral zone is a lot narrowed. this change would happen if you don't have estrogen there. This would happen with estrogen withdrawal. What changed? These are nice slides from Lancet 2002. And it was in these days, in the last 20 to 25 years, that the basic physiologists went and tried to understand how in the brain this happens, and then found the candy neurons. They found these neurons that have receptors for kisspeptin, for dynorphin, and most important for us, for the hot flashes, for NK3 receptors. These neurons were first studied in rats, and this is a nice paper published 12 years ago that talks about basic science in rats, so we can understand how everything works, how this interaction works between the preoptic hypothalamus, between the arcuate nucleus, where are the candy neurons, and how does it work with all the estrogen feedback. So we had this nice slide that can show us that in rats, this premenopausal rat had this infundibular nucleus that would be overexpressed, that would be completely the black dots when you are in a postmenopausal state without estrogen. So these candy neurons, they would be hypertrophic, they would be hyperactive when they don't have the estrogen there. When the receptor is not connected to the estrogen, you have a hyperactive stage of these candy neurons, and then you bring up the hot flashes because the mechanism is that you have an hypertrophy of the candy neurons. What we have then on this very, very nice review that was published last year in Temperature is trying to explain how all of this interacts. So we already had the hypothesis of an hour interthreshold zone with all the perimeral vasodilatation and sweating. We all know the circadian rhythms. We all know that hot flashes are more frequent in the end of the day, during the night. But then when we put here these candy neurons that become hyperactive in the arcuate nucleus, what happens is that the lower the estradiol levels are, the more active these neurons are. And so when they receive the receptors for the NK3 receptor, they bring up the hot flashes. And this was proven in the basic model in animals, but then we also found this neuron, this candy neuron in humans, and we have them in premenopausal and postmenopausal women, completely different, just like you had it in the rat. So when we look at this neuron, it's going to receive information from the ovary, and it's going to act by the glutamate path directly on the thermoregulatory neuron. And so you have this connection between the arcuate nucleus, between the preoptic area of the hypothalamus, and here these neurons are going to discharge the information in the preoptic area, and so they bring up the hot flashes. What did the studies do? So they developed blocking, they developed an antagonist for this NK3 receptor, and not allowing this NK3 receptor to bind to the candy neuron, you can block the beginning, you can block the first point, the first start point of the hot flashes, and you block it in the brain. So these candy neurons would act as a central pacemaker. They are in the arcuated nucleus, and in situations of low estradiol, they hyperactivate the signaling of NKB, NK3 receptor, and so you get loss of that trying to have internal hypothalamus arcuated nucleus feedback, and we have this evidence in animal models from the first papers of 12, 15 years ago, and now more contemporarily, we also have it in functional MRI and in physiology. And it really works because then we have antagonists for this receptor, antagonists for the NK3 receptor, and we have papers and we have commercialization of drugs that really in fast days or weeks, we should remember that usually estrogen takes 1 month to 6 weeks to control completely the hot flashes. This, as they act in this central pacemaker, these type of molecules are a lot faster. And what is the pathophysiology caused by the drop of estrogen levels, not only in vasomotor symptoms, but during all menopause? As we all know, it's important for this regulation, for the thermoregulatory, 75 to 80% are going to have vasomotor symptoms, but the presence of estradiol is also important for sexual function, for normal vaginal, for normal libido, for normal vaginal secretions, and also important for cardiovascular risk and for the bone. We should never forget that when we look at the WHI, the Cochrane database always says, when you talk about bone, there's not best drug than estradiol to act in the two types, bone formation and bone resorption. So when we look at estradiol as the first SERM, we can never forget bone osteoporosis and osteopenia. But during menopause, these are the main symptoms. And as you can look to this slide, they happen in the head, they happen in the face, they really are very cumbersome. You have the nice executive of 52, 53 trying to have a meeting, trying to have a webinar, and they start sweating. And we know that when put to stress, because it acts also in the serotonin pathway, is when women during stress for a meeting, for a big decision, they are going to have more hot flashes. They are going to have the complete perspiration, the shaking. Sometimes they feel so sick that they are really having dizziness and fainting. And this is something that's not going to disappear in 1 year or 2 years. We know from the studies that, for example, in Black women, you can have this type of symptoms 10, 15, 20 years post-menopause. So you should not have that idea that you can buy air conditioned, but because you're going to have vasomotor symptoms just for 1 year or 2 years. As we can see on this graph, usually you can have, and sometimes high vasomotor symptoms till 10 years post-menopausal. This continuum of bad quality of life, of bad sleep, of not feeling in control of your life, that's the most cumbersome symptoms of having VMS. Then sexual dysfunction is a very common symptom in menopausal women. We can talk about estrogen and his paper in sexual dysfunction, and we can also talk about androgens. What's true, it's from 38 to 85% is a very high number. And as we all know, even from the great work of Fulvio Coronado and friends for the Cervantes scale of quality of life in menopause, we know that a higher quality of life is always related to a better sexual desire in postmenopausal women. And we can talk this to the other side around. When you have better sexual function, you have a better menopause with a higher quality of life. In menopause, as we know, the vulvovaginal atrophy, the genitourinary syndrome, is one of the main culprits when you talk about pain, when you talk about decreased libido, when you talk about avoidance of intimacy. But it's not only that. In older women, when you are 80, 85, as we all know, is a cause of death. Having a genitourinary syndrome, having a big vulvovaginal atrophy is something that when you have a broken hip, when you are admitted to the hospital, is going to have you with worse UTIs, is going to have you with UTIs that are resistant to antimicrobials. So it can even give you a urosepsis, and you can even die for having a bad vulvovaginal atrophy. So when you talk about this nice revision from last year, March 2024, is for us to talk about microbiome. We cannot do a lecture in our days that we don't talk about artificial intelligence and microbiome. And so when I was looking for some papers for having this relation between genitourinary syndrome and microbiome, what we know is that we really don't know so much about this interaction. We know that in premenopausal cohorts, Black women are less likely to have a normal community with a prevalence of crispatus than white women. And we also know that Hispanic and Black women have a higher prevalence of bacterial vaginosis. What's Funny is that when you look of papers for postmenopausal women, usually we don't have this type of studies trying to show us what type of microbiome prevalence we have by ethnicity, race, and usually when we find studies, you have very small numbers. I can put you this table here, and we can see, of course, when women are doing estrogen therapy, when they are doing hormonal therapy, systemic or locally, you are going to find, as in these studies of COSI, a better microbiome with the dominance of the nice lactobacillus that we want. But as you can see on these COSI studies, they are in women that are asymptomatic. So they don't have GSM symptoms. We are giving them hormones, and you see difference between the lactobacillus dominant proportions, but it's asymptomatic women. What, for me as a doctor, try to understand this one. We have, okay, it's a small study from Hillier. It only has 73 women, but they are postmenopausal. They don't have the correct microbiome, but they are asymptomatic. So you don't have a dominant ambience of lactobacillus, but you have women with no symptoms. So for the doctors, we can always say that the best treatment for GSM is estradiol, is estrogen. Even low dose estrogen topically, vaginally, is going to make a big result. But when we look for the improvements, we know that we have patients that we treat them well, they get a nice lower pH, they get a nice vaginal maturation index, but they still have symptoms. So is it the microbiome here? No, the problem is that when we give them estradiol, we see profound changes in microbiota, we see profound changes in the better, lower vaginal pH, but these type of changes appear in all type of women, the ones that improve symptoms, and unfortunately, in the women that the symptoms maintain there. So sometimes we treat them correctly, we go for the physical exam and they are better, but they still have some questions. Then we can always look for the big confounders. We can always look for bacterial vaginosis. And here, as we all know, we have lots of papers with this Hamsel criteria, the need of 3 or 4 of the 4 criteria to have the diagnosis. But as we know, usually women in postmenopausal, they have a higher pH, and it's very difficult to use the standard Hamsel criteria to have a diagnosis of bacterial vaginosis in postmenopausal women. So here, the paper of the microscopy, finding that clue cells in the microscopy is one of the major uses that you can use for a microscope in the clinical practice in postmenopausal women. Then we have that rare situation of having a descamatov inflammatory vaginitis, but when you look at the symptoms, they are very similar to the ones that you have with GSM and to the ones where you have when you have a vulvovaginal by Candida. So what we are going to do? Are we going to go for the microscopy and find the inflammatory cells, the parabasal epithelial cells, so we can have the diagnosis and treat properly our patients? Sometimes it's not only GSM. If you are treating them well for GSM, don't pretend to know the sexual life of your patients. Go for the STs, go for bacterial vaginosis, and sometimes find the correct descamative inflammatory vaginitis so you can treat your patients. So here we have the epithelium that's responsive to estrogen, and then we have it in presence of estrogen. You have a nice epithelium. When you have lower estrogen, you will also know that you have more sensitization of the neurobiology, of the nerval pathway of the vagina, of the vulva. We have more vulvodynia in these patients. And so the symptoms of burning and of dyspareunia are there. And of course, when you have lower estrogen, you have more atrophy of the mucosa, more problems with the defense, the local defense, and you are going to have a worse urethral defense for the bed bugs and have more UTIs. What do you know about microbiome? Okay, you have low estrogen, you have less lactobacillus, you have a higher pH, you have dysbiosis and inflammation, but we need more studies to try to understand what type of microbiome gives one complaint or other complaint, and it's not being very easy because we really have to put different populations in microbiomes, genetic studies to try to understand if you have different microbiomes for different race, ethnicities, age along menopause, to try to find a correct correlation between microbiome and pain, dyspareunia, burning sensations in the vulvovaginal walls. How do we manage women in menopause? I'm here using the Spanish guidelines. In Portugal, we are trying to validate, and it's going to end till the end of this year, the Cervantes scale, because you cannot treat someone that you really don't know how is going with the symptoms, how is going, if it's going better or it's going worse. And when you have the great Cervantes scale from the Spanish Menopause Association, the work, as I was already telling you, of Pluvio Coronado and friends, we can divide the women on two types. And look, in these guidelines, and this is in Spanish, but I can tell you, they want vasomotor symptoms there. The woman has to have vasomotor symptoms, so you can start dividing them in moderate, low vasomotor symptoms, and you treat it one way of the organigram, or you have a high presentation of vasomotor symptoms and the other complaints of menopause, and you go for classic hormonal therapy of menopause. So it's important to have the vasomotor symptoms there, because if you have a woman that has low impact, moderate vasomotor symptoms, that they don't complain so much, and then she goes for the consultation for other complaints, then you can treat them with phytotherapeutic products, because she's not going to need, as a first approach, of estradiol, tibolone, or whatever used as hormonal products. You can rest assured, I'm not going to defend phytotherapeutic products without this main slide. Menopausal hormone therapy is the first line treatment for managing menopausal symptoms. You can really be sure that when we look to all the things that we have to treat these women, hormones and menopause hormone therapy is always the first line treatment, is always the choice. But you can have women that are not candidates for hormones, that they don't want to use hormones. And we all know them, the women with gynecological cancers, and here the breast cancer is the main culprit, putting women away from hormones. Women that already had thromboembolic events, a pulmonary embolism, a thrombovenous on the lower limbs, or a active arterial disease, a myocardial infarction, or they have an hepatic problem, an active hepatic problem. This type of woman should not use hormonal therapy. And we also have this. You do your best, you explain everything, you explain risks, but women don't want to use hormones. And so for this, we go back to the guidelines of the Spanish Association. We can talk about phytotherapy around the world is the most frequently used therapy for menopausal symptoms. And when you talk historically, yes, we all know that we've been using hormones for the last 75, 80 years, but we've been using plants for the last 4,000, 5,000 years. And we have some studies that show improvement on cardiovascular risk, on bone health, and sleep complaints. So why don't we use them? Or why do you still think that they don't work? These are for identifying the gaps in menopause management. We have women with symptoms, we have doctors that don't want to know, and sometimes not very easy to try to put the two together. This is a paper that we published in Maturitas this year about this. We are starting to have more women with an awareness of menopause, but menopause training is lacking. And so improving menopause medical education is crucial for all, not only for OBGYNs, but for family doctors, for internal medicine, for endocrinology. We all should look to this part of women's health as one of the most important when we talk about quality of life in menopause. And so when we look for the main phytotherapies for managing menopause, they are not so strange, they are not so obscure. We have lots of publications with black cohosh, with hopes, 4,000 when we talk about isoflavones of soy, and even almost 4,000 when we talk about the extract of pollen. So we have papers that show that they work in vasomotor symptoms, that they work in insomnia, and sometimes that an alcohol work to improving sexual function. And as Santiago was telling here, Trigonella looks like a very nice product. And talking about Simifuga racemosa, black cohosh, here is a very nice review and meta-analysis that was coordinated by Camil, Castelo-Branco, our dear chairman. And we can see that all the studies on this meta-analysis, they favor the use of the black cohosh extract for menopausal symptoms. And you can see on this table that sometimes you have some concerns and you have the yellow dots there, but the main dots are the green dots. So they are safe and they provide some results. And why? Because they are going to work on that serotonin replicate in the synaptic cleft. I was telling you, you have that two views, the thermoregulatory view of GnRH, FSH, LH, and here the candy neurons are going to work. But then we have the other pathway, the pathway that tell us that we can use SSRIs to treat vasomotor symptoms in women with breast cancer, and that we can use this serotonin pathway that's completely independent of the estrogen pathway. So when you treat them with black cohosh, you are going to have more serotonin uptake in the synaptic cleft. You are going to have upper of the serotonin and so less symptoms. And with hops, how it works. Various studies have shown that hop extract reduce vasomotor symptoms, and we have studies that have 15 years, that have almost 20 years. And we know that even with 100 micrograms of hop extract, you are going to have a lower dose at 6 weeks and at 12 weeks of a hot flush scars. And all menopausing rating scale and visual scale show that you are going to have this mimic effect. Hops really acts like almost a SERM. It goes to the receptor estrogen alpha and it mimics the endogen estrogen effect. And so it triggers some transcriptional activity that's induced for the endogen estrogens. That's why you should not use hops extract in women with breast cancer, because it has some estrogen-like effects, but you can use in all the other women that have low to moderate vasomotor symptoms and want to have this effect in communion with the Simifuga effects. So when you have a product that has the two together, you should be aware that you should not use it in women with breast cancer because of that estrogen effect that the hops extract has. But treating vasomotor symptoms and insomnia, you are going to have a ligation of the two pathways, the thermoregulatory center by this hop direct effect in the receptor estrogen alpha, and then the normalization of the thermoregulatory response with a serotonergic effect of black cohosh. And sexual function. For that, I found this nice paper. Okay, you can tell that the number of participants is not so high. We need more women, but it looks that Trigonella has shown efficacy improving female sexual function, and it does that because it puts estradiol up, and it also inhibiting this incomplete reductase, these 5-alpha reductase. It allows free testosterone to go free as it should, and so it also works in the androgen way, in the androgen pathway for improving sexual functions. So for ending, my general conclusions, vasomotors and GSM are the most common symptoms affecting menopause. And if you find the correct answers, first you need to do the correct questions. And here, finding the central pacemaker, the candy neurons and their neurobiology was very important to understand and completely understand the thermoregulatory model. And here we can see that these neurons are going now to have some studies with kisspeptins for libido, with kisspeptins for reproductive biology. So we are starting to understand that really in women all starts in the brain. When we talk about GSM, we already know about the estrogen effect, and it's essential. So even if you don't give anything else, if the woman has complaints of genitourinary syndrome, you should start them on local estrogens, and you are going to have there a better pH, a better vaginal maturation index, and in the long run, 2 months, 3 months, a better health and control of some symptoms. We still need to have more studies for microbiome to try to understand, but we can be sure of one thing: local probiotics are not going to work. We have lots of reviews that say to change the microbiome of the vagina, we have to go by orally, we have to go by the gut, we have to go by the bladder microbiome, because if you put them, they are going to be destroyed and are not going to work. And then that shared decision between the patient and between the doctors. We should not know everything. Only ChatGPT or Gemini knows everything, and you know how that works. And so we should talk to the patients. They are getting enough information, sometimes too much information from the internet, and we should talk about phytotherapeutic products in the first line. As Santiago was telling, for the first month, 3 months, when we talk about women with low or moderate symptoms, because sometimes you are going to treat them correctly, you are not going to use hormones as a first line for that low intensity symptoms. And when we talk in older women, that we are more afraid when they are 10, 15 years, 20 years post-menopause, try the phytotherapeutic products, because if you have nice results, they are going to maintain the treatment and have a better quality of life. And when you talk about sexual function, yes, I was looking at Santiago's, but here, as we know, this is Trigonella. It's a nice product, but as we know, improving sexual function is a lot more than only having a bit more of estradiol, a bit more of free testosterone. So I put there my sign, not being very sure if you are going to have some nice results improving sexual function only with that. But if you treat GSM and then we improve with this type of products, maybe you are going to have a new woman for this period of life. And that's it. Thank you for your attention. Thank you, Camil.
Thank you, Claudio, for your nice presentation. As we can expect, nice and excellent lectures have arisen a lot of questions, and I have difficult to choose the one for each of you, because there are many, many questions. But let's start with Santiago. Santiago, can we demand the same level of evidence to phytotherapy as we demand for a prescription drug?
Well, I think that, as I said before, I think that there are 3 clear steps when you are going to offer, not only menopause, in a lot of different diseases or alterations. Always you need to recommend diet and exercise and habits. But before taking the decision of a drug with the efficacy, but with the side effects too, we have the possibility to offer fat supplements. And this is something logical and with less side effect. That means that the evidence is enough for thinking and speaking with the patient about the possibility to offer this. And as Claudia and myself, we said exactly before, if it's not work after 3 months, of course, is the moment for making a change for a real drug. This is my idea, and this is my answer.
Yeah, but following this question, another person from the audience request what is the best evidence, and they suggest meta-analysis, randomized double-blind clinical trial.
Well, the ideal will be a meta-analysis of different double-blind placebo-controlled studies. And I absolutely agree that we need, with this new approach that is the combination of different fat supplements that works in different manner, we think that we need to do first double-blind placebo-controlled studies, and of course, after this, we need to have meta-analysis. It exactly is the way that we need to do. I agree absolutely that we need more and we need to work in this way.
Thanks, Santiago. And one question for Claudio. This is an interesting question. Are vasomotor symptoms simply a response to the estrogen withdrawal, or they represent a systematic stress response that may have long-term cardiometabolic consequence? And this is linked with the many epidemiological studies that,
of course,
that establish a link between the vasomotor symptoms and cardiovascular disease. So I think that it's a very interesting question, this one.
Thank you, Camille. Very nice question. Yes, of course. When we talk about vasomotor symptoms, they are sometimes the first sign of endothelial damage already. So when we know from all the studies and meta-analysis that women that have a higher frequency, a higher intensity of vasomotor symptoms, they have a higher cardiovascular risk, they have low dilatation, we understand that. We know that estradiol, by the pathway of nitrous oxide acid, also is a vasodilator. But when we talk about this, we should know that people are very different, and we are looking at the genetics of the problem and epigenetics. And it's important, this identification of the candineurons, because when we look at the chromosome 17 and chromosome 11 in different patients, we know that you have there a loci for the TRAC3 gene that's going to talk about expression of that NK3 receptor. So finding this candineuron is important for the thermoregulatory pathway and to explain to us why when you take out the ovaries in surgery and you have that big and fast estrogen drop, the vasomotor symptoms are going to be more intense. But when we talk of women that enter naturally in menopause, it's going to be this genetic pathway of the candineuron, of the expression of NK3 receptors, that's going to explain us the baseline of vasomotor symptoms. But when they have more symptoms than a sibling, that's because sometimes you have the cardiovascular risk, the endothelial damage that she was doing to her last life, the last 20 years, 30 years. So we know that when a woman smokes, okay, she's going to have more symptoms, and it's not the problem on candineurons or estrogen withdrawal, is that their endothelium is different. And when we talk about vasoperipheral constriction and all the mechanisms of having the hot flashes, they are more intense on this type of women. So we should look at these symptoms with the importance and relevance they have. They are a marker of cardiovascular disease, and we should treat them. And as Santiago was telling, we can start treating them when they are low to moderate with this type of phytotherapeutic products. When you talk about randomized controlled trials, when you talk about doing really science with that, it's going to be difficult because we have so many different products, so different doses, so different countries that would have to do a study of a multicentric. But for my clinical practice, I still prefer Simicifuga, Racemosa, Black Cohosh, and Poland's extracts for my personal view of more evidence in my clinical practice. But I have to agree that we need randomized control trials with the correct products in the correct dosage. When we compare them with isoflavones, they are so different. You have such different compositions, it's not going to be very easy to do a randomized control trial and then a meta-analysis of that randomized control trial. But I agree with the colleague that made the question. We should look at vasomotor symptoms as a first sign that things are not going well. And yes, you have the estrogen mechanism, you have the serotoninergic mechanism, but they are a marker, and a marker of a broader perspective of health of that woman.
Thank you for your extensive answer. Santiago, we have many short questions, and I ask you for a short answers. First from Manoy Yadat, that say, how effective are isoflavones for the management of menopausal symptoms? And If so, for how long should we use?
Well, the question Claudio said before, the problem of the isoflavones is that there are so many kind of isoflavones with a different concentration, purity, and so on. But you need to analyze the isoflavones that you have in your hands, the possibility that you have in your hands. And after this, I think that you can use for so many years. If the women, they don't have any estrogen receptor cancer, and because depending on the isoflavones or phytoestrogen, you can use for several years. And the unique point to stop it is when they have any point in relation with estrogen receptor, as for example, bleeding disorders or cancer, as breast cancer, for example.
Thank you, Santiago. And just in the same lane, Marisol Fernandez asked, can be used in patient survivors of breast cancer? Your answer.
Yeah, the unique
Hold on.
that you can use is with black host, because as you know, well, but we have no strict restriction for it. We have some concern, but no restriction, because they is a modulator of the serotonin receptors. It's not working directly in the alpha and beta estrogen receptor, but the other phytoestrogen, no, because they work through estrogen receptors.
In fact, there are several studies with samicifugal racemosa in breast cancer survivors.
Yeah, for this, exactly. This is the unit that you can use.
And for another phytotherapeutic product is Trigonella. And can we use Trigonella in breast cancer survivors? This is another question also from Marisol Fernandez. Since Trigonella, yeah, please, Santiago.
No. Well, the Trigonella, we have no exactly data about the work in the receptor, but in general terms, if you don't know the result, you need to avoid.
Yeah, well, in fact, Trigonella, if it's true that increase the testosterone level, testosterone is the source of estrogen, so can be contraindicated.
Exactly, because you are going to increase the own production.
Another question from Irina Podaneva, says just to Santiago, what is your opinion on resveratrol, on the use of resveratrol?
Well, the resveratrol, for me, depends on the doses. We have data to show that the resveratrol, they can decrease vasomotor symptoms, is a vasodilatator too, an antioxidant too, and they increase, even though the bone mineral density. But the point for me is the doses. The doses, you can use doses until 500 milligrams per day with any problem, but the usual doses is between 150 to 250. If you use these doses, you can have some efficacy. If you use less, no. That means that depends on the doses.
And Mario Flynn from Ireland asked also to Santiago, but I think that Claudio can give an answer too, is, are you concerned on the effect of black cohosh on endometrial proliferation?
This is a beautiful question, because, of course, we know black cohosh doesn't work directly in the estrogen receptor alpha and beta, but they could work as the partial agonist of selective modulator, activity. And then there are some words about the non-genomic pathway. In other words, we need to be careful. Theoretically, the answer is, because this is a difficult question, the answer is, theoretically, you can prescribe, I am not concerned with black cohosh. But probably there are other different mechanisms that they can influence, because in fact there are some estrogen activity in some other tissue. That means that, well, be careful.
I would say, from my clinical point of view, if that woman has other risk factors for endometrial pathology. If she's obese, if she's nulliparous, I would prefer not to use black cohosh.
Yeah,
Because
this
as
could be.
Santiago was telling, we have some mixed evidence that it can happen something to that endometrium. So if she has other risk factors, I'll prefer to have pollen extracts or other type of choice because they look a lot safer in endometrial. That's my personal view.
No, but I agree with you. That this is something beautiful because probably we need to know in the future something more
how it
about
works.
this
Yeah.
non-genomic
Non-genomic effects. Yes, a non-genomic pathway. Yeah.
Two questions from Manoy Yadab, both related to genitourinary syndrome. The first one is for how long we can use estrogen cream vaginally for the reduction of genitourinary symptoms?
Till dying, till the funeral parlor. So women should start it, and from the different products you can have high dose, you can have every day, but then you can use it as a maintenance therapy for 90, 95, 100 years old. If you look, and you have this idea always of sexual function, but even if they don't have sexual intercourse, even if they don't have that type of complaints, the atrophia is going to be there. So I have patients of 92, 93 that their caretakers still use, their caregivers still use and still apply the cream 2 times per week till they go for the caretakers. So for me, when you can have the patient treated is for whole life.
Well, another practical question related to genitourinary syndrome of menopause also by Mano Biadab ask another question. Is that menopausal in a menopausal lady when during an examination cervix looks healthy, but the pap smear shows atrophic vaginitis? It is necessary to treat atrophic vaginitis in this case, and for how long?
Yes. It depends. You are treating.
If I understand the question, because I
Yes.
read as is.
The concept is the prevention.
Yes.
The question is, in an asymptomatic woman, a
Yes.
pap smear reveals atrophic vaginitis. Should be
Yes.
great?
Yes. That's the question of what to treat and not to treat. If that woman is completely asymptomatic and the physical exam is completely normal, what's going to be strange is that you have a pathologist that's going to give you something that you are not looking for it, okay? We don't treat pathologies, we don't treat pathologists pap smears, we don't do it with candida, we don't do it when they find an actinomyces. If you don't have any type of symptoms and if you don't have any type of signs in the physical exam. For me, it would be worrisome why that diagnosis appeared, because usually when that women have atrophy in the cervix, you really see it around the rest of the pathway. You see the petechia, you put the specula slowly and it bleeds. So I have to agree with Santiago. We can always treat for prevention of the atrophic, but if you don't see any sign and if they don't have any complaint, it's not very easy to tell the women you are going to start a treatment for preventing something that you don't have now. You do that for osteoporosis, but you have exams, you have risks. If you don't see it, I think that you should not treat it.
Yeah, but I agree with you, but for me, this is a beautiful question. Open one of the issues that is in relation with the prevention, because we know, we published one paper in Maturitas to say that if you trade what's called with fospemifene,
Yes.
if you trade moderate symptoms, vulvovaginal symptoms, you're going to have better result than when you trade severe.
Of
In other
course.
words, as soon as possible, you are going to have better result. And the question that is open is, and why not to prevent to all ladies when they arrive to the menopause to avoid to have moderate and severe symptoms? Because the good point is that the side effects of the local estrogen is
Zero. Yes.
In other words, why no? But probably I agree with you, Claudio, that if you are going to see again this lady in 6 months or 1 year,
She's
maybe
going
you
to
can,
have
you
symptoms.
can explain to the patient when you will start with some symptoms, please tell me and I'm going to prescribe something.
Yes. Or you can prescribe and they start for the first symptoms.
Yeah,
It's
I
going to
agree.
happen. Yeah.
Well, this is another question. This is an interesting question from Catherine Martins from the Netherlands that says that he works in a health organization, Care for Women in the Netherlands, and he's treating women for over 25 years with supplements. And the question is if any of you has research already been conducted into the relationship between deficiencies in essential nutrients, such as selenium or zinc, in the severity of vasomotor symptoms.
This is a fantastic question.
This is very
The
nice.
magnesium, the selenium, and the
The
zinc,
zinc.
and the vasomotor symptoms.
Yeah.
This is open. This is open.
Well, we are exhausting our time, and we have just one additional question to Claudio. Is about microbiome.
Yeah.
Recently, the oldest woman in the world was a Catalan woman who died a few months ago at the age of 117. And now the researchers are studying her microbiome. And they found that the microbiome of this lady was the same that they observed in healthy women in their 30. So my question is, what about microbiome transplantation? Can we make a transplantation of the microbiome of a healthy woman in their 30 to an old one in their 80 and improve the quality of life and the life expectancy?
That's a tough one, Camil. What we know about microbiome transplantation, we know it for Crohn's disease, and we know it for some patients that have usually intestinal dysbiosis and very bad intestinal dysbiosis. And so that's what we have published. Now in Portugal, we have a colleague of ours from nutrition that are starting her project in Lisbon to have microbiome transplantation for other types of diseases. The problem here is that we have two things in women. We are looking to vaginal microbiome that correlates a lot with intestinal microbiome, but as we know, the intestinal microbiome is really a metabolome. We know that you have some pathogenics there that produce estrogen that can up the risk of breast cancer, for example. So I would like to know the nutrition of that old lady of Catalan. I would like to know the physical exercise. I'd like to know, because we understand that trying to change the microbiome, it starts when the people is born, when you don't have antibiotics on your first 6 years of life to have a healthy microbiome for the rest of your life. You really have to concentrate on the first years of life to have a good selection of microbiome. And if you want to do a transplantation, you should freeze the microbiome when you are 18 or 19, something like that, and then use it posteriorly. The difficulty here is what you are going to do. You are going to freeze your own microbiome, or are you thinking of using that microbiome of that old lady and do a therapeutic transplantation of microbiome from different persons? So the discussions here is that you have some evidence on the intestinal, but we don't have evidence for treating vasomotor symptoms, for treating GSM, because it's a lot harder to find correlation between symptoms of menopause, problems of disease. And when we talk about intestinal microbiome, we are talking about intestinal disease, Crohn's disease. We are talking about some studies that correlate psychiatrist disease, depression with intestinal microbiome, but I cannot find for the typical vasomotor symptoms or for the typical GSM symptoms of women in menopause treatments by the microbiome. We don't have that.
In fact,
this lady, I remember that this lady was taking, the oldest lady in the world
was still doing hormones, no?
3 Jaeger per day.
Oh, okay.
And now the place that is producing this yogurt is absolutely
Selling a
very
lot.
happy because they have a big successful.
Well, in fact, we need a good genes and a healthy lifestyle and a good
Yes.
microbiome to increase our lifespan. So, unfortunately, we have no more time, and I wish, before to give thanks to our speakers, I wish to highlight two essential points of your lectures. The first one is the importance of the shared decision that Santiago started his lecture. In fact, there are two different concepts that are compliance and adherence, because compliance means that the patient do that the doctor says, and adherence is that the patients accept the therapeutic rules.
Value, yeah.
So I think that the shared decision is the key to improve the goals of any therapy. And the second one is the importance of standardized products. We are talking in these lectures, Santiago and Cláudio, you present data on food supplements, but both are standardized products. We are not talking about herbals that we can
Buy anywhere.
buy in an herbal shop. We are talking about standardized products with good production lines. So I think that these are the two main points and the important points that we need to highlight after your lectures. So thank you very much, Santiago.
Thanks.
Thank you very much, Cláudio, for your excellent lectures and for all the knowledge that you share with us.
Thank you.
Bye bye. Thank you.
Bye.
See you.
Bye.
Enjoy.
Bye.